Okay, I'm back to give a brief review of PCI in patients with stable ischemic heart disease, and perhaps this will serve as a partial rebuttal to the physiologists you just heard, because this is based a little bit more on anatomy, I must say, which is how we've been making decisions for 40 years. I only have 15 minutes. I want to briefly highlight the difference between simple coronary artery disease and complex coronary artery disease, make a comment on the COURAGE trial and the ORBITA trial, and briefly talk about left main and chronic total occlusions, which are the hot topics in stable ischemic heart disease and PCI. We saw two excellent presentations this afternoon on those two subjects with very nice results. But first, let's pay honor to Andreas Grunzig, who 40 years ago and 9 months did the first PCI after several years of trying to figure out how to do it. He had great trouble finding the first patient who had a single isolated proximal LAD disease. He had crescendo angina. He had a positive treadmill test result. So he had symptoms, he had ischemia, and he had anatomy. And when the balloon dilated, the obstructive stenosis, which was the cause for all three of those variables, the stress test went back to normal, the chest pain went away, and he did well. So it's curious to me that 40 years later we're still arguing whether or not PCI reduces chest pain and reduces myocardial ischemia, because it did on the first patient, and even an interventional cardiologist can understand that concept. You saw this slide on the COURAGE trial. I was actually one of the investigators on this study. It demonstrated nothing new, but caused great outrage in the PCI community based on how it was interpreted. There were at least a dozen studies before COURAGE that showed that PCI in stable ischemic heart disease did not change mortality or non-fatal MI rates, and there have been at least a dozen trials since then showing exactly the same thing. A couple of them I'll show you. But this really bothered the interventional cardiology community, who thought PCI was under attack. But what does PCI do? It doesn't change MI rates or mortality rates, and that's the message I want to leave with you today. It relieves angina and it improves ischemic stress tests. And if you look at the literature on PCI versus optimal medical therapy, it's very consistent. PCI makes angina goes away, it makes stress tests better, and because of that, you have a better quality of life. It does not reduce mortality or MI rates, because those are due to vulnerable plaques, which are not predicted by stress testing or a coronary angiogram. So here we are 11 years later. You probably have heard about this ORBITA trial, which was brilliantly conducted by Dr. Al Lameh, and had a wonderful methodology, the best of any PCI trial I've ever seen, and has been badly misinterpreted, as was the COURAGE trial. The manuscript they turned in, I am told by my interventional cardiology colleagues, I must say, was not the same manuscript that was published by The Lancet, when the editorialists, who I assume were the reviewers, and the editors thought they could make another strong statement to attract a lot of attention on interventional cardiology and stable ischemic heart disease. The conclusion I will read to you: in patients with medically treated angina and severe coronary stenosis, PCI did not increase exercise time by more than the effect of a placebo procedure. And the editorial written by Brown and Redbert said, "Last nail in the coffin for PCI and stable angina," which was an outrageous statement based on 40 years of experience. The paper I think the investigators wished to publish was just published in Circulation. Same study, different interpretation. The editors and the editorialists did not get involved, and their conclusion was in patients with stable angina and severe single vessel disease, the blinded effect of PCI was more clearly seen by stress echocardiography score and freedom from angina than change in treadmill exercise time. Moreover, the lower the FFR or the IFR, the greater the magnitude of stress echocardiographic improvement caused by PCI. Again, PCI relieves coronary symptoms if it's ischemic heart pain and not non-cardiac pain, and it improves exercise tests. This is the same result that Dr. Grunzig demonstrated on his first patient, and I'm not sure why we're arguing about the Orbita trial, other than it's going to increase the impact factor of the Lancet Journal to the editor's delight. The only revascularization intervention that does prolong life is surgery with a left internal mammary artery graft to the left anterior descending artery. It's not clear that saphenous vein grafts do any better than a stent in relieving ischemia. They have not been shown to demonstrate a survival benefit. So if we want to talk about IFR or FFR or the COURAGE trial or Orbita, we need to look at the endpoints we're discussing. We can't lump them all together as major adverse cardiac events. In fact, to push back on the physiologists, I would say the reduction in those endpoints is not death or MI because those outcomes are not changed by elective PCI. It's reduction in target vessel revascularization if you leave a high-grade stenosis and try to treat it medically, even though it has a class 1 indication for PCI. Let me switch to surgery versus PCI. The Syntax trial now is 5 years old. And again, based on anatomy and complexity, they have this very nice Syntax score, which most people don't use because it takes some time to compute. But the simple concept is that if you have simple disease, PCI is as good as CABG, the standard of care that we've been practicing probably for 20 years. If you have complex or three-vessel disease, left main disease and three-vessel disease, surgery does better in every trial before Syntax and in every trial after Syntax. Why is that? Probably because the left internal mammary artery graft bypasses 8-10 centimeters of vulnerable plaques, whereas PCI is only a focal treatment. And intermediate-wise, we can argue whether surgery is better than medicine on a population level, but as I will state at the end, for the individual level, this may not be as important, but more complex patients still do better for death and MI rates with surgery, and I have to admit that as an interventional cardiologist. But there is three-vessel disease and three-vessel disease. They're different. On the left panel, I would argue, is a patient with three-vessel disease that might be amenable to PCI, and in the Syntax trial, patients who got 4 stents or less did just as well with PCI as with surgery, number of stents being a surrogate for complexity of disease. Here you see focal disease in the left circumflex artery, the left anterior descending artery, and 2 lesions in the right coronary artery. Fairly straightforward for doing PCI in 1 setting or 2 settings. So PCI might be very competitive with bypass or even preferred in this patient. In contrast, on the right, you see a tight left main stenosis, you see a tight LAD stenosis, you see an occluded circumflex artery, you see an occluded right coronary artery. Perhaps Dr. Colombo or some of the operators this afternoon can make that look better, but I don't have those skills, and I would argue that this patient is best treated with bypass graft surgery and not with PCI. So complexity is a very important variable to consider, and it's based on anatomy in addition to the physiology information we would like to have. A couple comments on left main disease. This is still defined anatomically as a percent diameter stenosis of greater than 50%. And some would argue IVUS using anatomic measurements might have some advantage over FFR because of the downstream disease and the complexity of trying to figure out what's happening in the main stem. We describe it as ostial and mid-shaft. Those have become very attractive targets for PCI and perhaps preferred. And we saw a very nice complex distal PCI case today. That still may be a surgical indication for most operators, though there are some excellent operators now who can achieve good outcomes. But they need to be done by the best operators, not by routine operators. This curve is a little bit of a misrepresentation of the point I want to make, but it does summarize in a meta-analysis 4 trials looking at left main disease of PCI versus CABG. And rather than looking at the numbers, I want to emphasize the point that CABG is a little bit of early risk and a higher risk of stroke, whereas it has a lower risk of recurrent MI. And in all of the trials in diabetes and in left main disease and in three-vessel disease, you will see the event curve for CABG is flatter than the event curve for PCI, and I think that's mostly due to recurrent myocardial infarction, which again, stents don't do a very good job at preventing. So we have to argue the durability of CABG is probably better at a population level if we're just looking for p-values. There are some challenges in left main stenting. It's become routine for people that have the variables on the left. It's more challenging for those variables that are in the red box, but is increasingly being done as we get more experienced with our equipment and our technique and our protocols for trying to treat these patients percutaneously. A brief comment on CTO indications. We just saw two beautiful cases. Let me remind you that left main disease is different than CTO. CTOs are done in ischemic heart disease patients, and no intervention on ischemic heart disease that's stable has been shown to improve mortality or LV functional recovery. Same story. It improves symptoms and improves ischemia. This was shown by Dr. Park, who is perhaps the world leader on this, in an observational study showing no difference in death or MI. Remember, those are the endpoints, not target vessel revascularization, not angina, not a positive stress test. And he recently presented, but has not yet published, the Decision CTO study, which showed exactly the same curves. So the benefit risk calculation for a patient who has a chronic total occlusion is a little bit different than the same calculation for somebody with a patent artery and a stenosis, where the complication rates are lower. As we saw in these very complicated patients last hour, there's an increase in contrast load, there's an increase in radiation exposure, it takes more lab time, success rates are not as good as with a patent artery, and there are some complications one has to know how to deal with. There has been no change in left ventricular ejection fraction in a small study called EXPLORE, and again, no change in mortality risk. So to get informed consent, we really need to choose the patients who have a very high success rate of having a successful procedure, say 90%, and we need to make sure they're burdened by angina and ischemia that is not relieved by optimal medical therapy. So we've argued about PCI and CABG now for 40 years. I actually think they're complementary strategies rather than competitive strategies. I've been in this business for 40 years now. I think the message has been consistent across the time span. CABG still probably has some benefits in patients with more extensive or complex disease. We're still arguing whether it has benefit in more severe LV dysfunction. The surgeons are actually sending some of those patients to us now for PCI. It probably has more benefit in insulin-dependent diabetes, and I think, although we've made dramatic improvements in CTO success rates, there's going to be a higher success rate in revascularizing occluded vessels with bypass graft surgery than with PCI. Conversely, PCI may be preferred as the initial revascularization strategy, particularly in young patients. In this part of the world, you have coronary disease occurring a decade younger than we do in the U.S. It may be preferred in patients with 1 or 2 vessel disease, and I would argue there are some patients with 3 vessel disease with focal stenosis who just do fine with PCI instead of bypass graft surgery. So as we all know, and now that the valvular disease folks have popularized this concept, the Syntax investigators, I think, deserve great credit for emphasizing shared decision-making with the heart team. Ad hoc procedures, particularly in complex patients, are increasingly being discouraged, though you can do it in simple patients. There are a number of complexities that need to be considered when making an individual patient decision on whether PCI or CABG might be preferred, and those include artery diameter and ambulation, plaque distribution and composition, simple versus complex anatomy, operator expertise, the risk-benefit of PCI versus CABG, and ultimately the patient preference. Thank you very much.